Thank you, Dr. Grishma, for that wonderful talk. Now, let me call Dr. Anitha Balachandran, professor and a great pediatric ophthalmologist, to tell us all about how to use our brains before we scan their brains. Over to you, Dr. Anitha. Dr. Anitha is professor at RIU Trivandrum.
Good afternoon, all. Thank you for including me in this session. I have few case scenarios which are actually neurological mimickers, but when you examine in detail, they are found to have a ocular etiology. First is a case of a 56-year-old lady who complained of intermittent diplopia, more so in the evening for the past 3-4 months. And she herself told that her diplopia was relieved on closing one eye. She had no precipitating factors, no headache, pain, and on examination, her ocular alignment and motility was within normal limits. She didn't have any ptosis, no fatigability. Anterior and posterior segment, there was nothing contributory. And so, with the history of binocular intermittent diplopia, more so in the evening, naturally myasthenia was suspected, and we did the whole lot of battery of tests for myasthenia, but everything came out to be normal. And because she had a vision of 6/12, which was improving to 6/6 with her new specs, the specs was given and was reassured and sent off, only to return a few months later, this time with constant diplopia. So what is the missing link? How is the diplopia relieved? She told it was relieved by closing one eye. It was relieved by closing the right eye and not left eye. So was it actually diplopia or polyopia or blur or halos or shadows? So we have to go in detail. And she was put into a slit lamp examination after dilatation, and she was found to have a early developing cataract. So what we thought as a true, binocular diplopia was actually a right monocular polyopia. It was more in the evening because the pupils were slightly dilated, and there was light scatter because more light entered the eye, and she was relieved by cataract extraction. Second is a case, so before reference, we have to verify if it is true as a diplopia, and if it's a diplopia, it's truly binocular, and do a pinhole test if possible, because pinhole occluder will relieve diplopia due to ocular aberration, media aberration, and refractive error. Second is a case of bilateral disc edema, which most of us would have encountered some time or the other. It was a 40-year-old lady who was obese, and she had progressive visual blur, and she had intense periodic headache. There was no preceding pain on movements. She had no known medical illness. On examination, vision was sufficiently good, anterior segment was within normal limits, only bilateral disc edema, and as expected, visual field was bilateral enlargement of blind spot. So naturally, papilledema is diagnosed, and naturally, in a hurry not to miss an intracranial space occupying lesion, we sent for a neurological reference, and emergency MRI was done. There's no cause contributory, and so because of her age and obesity, a benign intracranial hypertension was diagnosed, and naturally he was admitted to do a LP, and a bedside test clinched the diagnosis. Nowadays it's the duty of only the house surgeon to take the BP, so he was called in and he took the BP, and it was found to be very high, and ophthalmologist was again called back to do a dilated fundus examination, and it was diagnosed as a case of malignant hypertension, which when controlled the patient improved. So what is again the missing link? The age, the obesity, no relevant medical history, the headache, the transient visual obscuration, even the disc appearance mimic a true papilledema, as Dr. Grishma told. But for practical purposes, you have the presence of retinal hemorrhages and exudates. 1 disc diameter from the disc margin of the optic nerve head shows that there is a mechanism other than ICP, possibly vascular, contributing to it. So before embarking a case for neurological evaluation in a case of papilledema, a checkup of BP is mandatory, and a dilated fundus examination is absolutely necessary. This condition we all know is, it's not clear, it's an optic nerve drusen, naturally can be diagnosed without a CT scan by autofluorescence if it is superficial, or ultrasonography even in a buried drusen instead of taking a CT scan. Third is a case of a 65-year-old male who complained of episodic visual blur. He complained that it was maximum, it was right upon awakening itself he had felt that blur. which relieved to the baseline vision maybe after 1 or 2 hours. He had no inflammatory signs like pain, redness, or photophobia. He was diabetic and hypertensive. His vision was 612, which was attributed to a posterior capsular opacification because he had had a cataract surgery a few years earlier. So, a transient monocular visual loss, the usual cause is a retinal embolism, mostly from heart or carotids, which we call its Amaurosis fugax, or an ocular ischemic syndrome due to a varying degree of stenosis of the carotid. Accordingly, all the tests, including Doppler of the carotids, MRF, the cerebral results, cardiology, but nothing contributory. So, what is the missing link? A detailed history as to the onset of the blur, the duration of the blur, was there any precipitating factors? Amaurosis fugax is of abrupt onset and offset, and it lasts only for minutes. OAS is more gradual, more prolonged, and it's mostly precipitated by postural changes and bright light. What was it here? He had problem upon awakening itself, which lasted for hours. There was no precipitating factors. So he was called back at the time of his blur itself, early morning, and it was found that he had moderate corneal edema. A corneal pachymetry was as proved by the corneal pachymetry, which showed increased thickness and reduced cell count in specular microscopy. So the diagnosis of corneal decompensation, possibly due to an endothelial dystrophy, which might have been aggravated by the recent cataract surgery, and accordingly managed. The last case is of a 30-year-old female who was our lab technician. She complained of drooping of eyelids for about 6 months. She was very specific that it was very absent or even minimal when she went for work, but she had drooping in her right eye when she returned from work. She didn't have diplopia or any other precipitating factors. Vision was good, anterior segment and posterior segment, nothing contributory, and fatigability was present. Naturally, being ocular motility, everything normal, we suspected myasthenia again, worked up, non-contributory. But if you can see that she definitely had a ptosis in the right eye, and elevation was good enough. And this is the levator function, which is also very good. And what about the lid crease? It is the lid crease in the right eye is definitely higher than that in the left eye. And on looking down, the palpebral fissure in the ptotic eye is much narrower than the left eye. So considering all these 4 features, we diagnose it as an aponeurotic ptosis. And this is also a quite evident case of aponeurotic ptosis in an elderly lady, but it's very asymmetrical, and she had the ptosis in the left eye since her younger age itself. On raising his lid, you can see that he had inflammatory, post-inflammatory change as shown by the corneal scarring and the tarsal scarring. So, drooping of the eyelids was later in the day is common in myasthenia, but not specific to it. Other than senile aponeurotic ptosis, other factors which precipitates levator stretching are post-inflammatory, post-surgery, chronic rubbing, long-term use of contact lens, etc. They all overcome the ptosis in their initial time by their extra effort, which is difficult to maintain, and it causes a fatigability. These are all pictures of famous dancers, personalities. Do you think that they have deep sulcus and higher crease? Is it because they use their eyes more and stretch it by their arching of the lids? Something to think about. Thank you.
Thank you, Dr. Anitha, for throwing so much of insight into these common mimickers and providing us with so much of missing links. That was a wonderful talk. Thank you.